Yeah, I'm pleased to join you guys. Thank you very much for the invitation. Yeah, I'm fresh off the ICU from last week, and it seems like our numbers are generally going down, at least in the ICU, which is nice to know. But Jim asked me to give my thoughts on um, convalescent follow-up and kind of what we know so far. I feel like uh, COVID-19 is kind of like the neighbor that just moved in down the block. We've met them, we can recognize them, we kind of know how to make the diagnosis, but we don't know them very well. And it's a process of getting to understand this brand new disease that we don't really know yet well enough to be reliable. But we have seen some things that are common in the convalescent period, whether that's in the office or whether it's just people calling that family, friends, etc., coworkers. We see a lot of cough that persists for some time, exertional shortness of breath, which can persist, wheezing, fatigue, even some chest pain that seems to be atypical, and generally asthma-like symptoms. So basically, there are a number of interventions that we have used. I like to think of the COVID exposure, bronchial infection, lower respiratory tract infection, as how do we assess people that have an underlying lung disease who then get an exacerbant, or even some people who develop a lung disease, whether it's short-term or turns out to be chronic, which is a little bit hard to identify at this point, given the short time frame of our COVID experience. And what is the chronicity of that? Is it something that remains subacute for some time? Does it maybe perhaps never leave the person as they were? It's hard to say. But in general, if I have a patient who comes in with a short-term exposure, whether that's occupational, environmental, or even infectious for people that have had a serious case of bronchitis and no previous underlying lung disease, or whether or not they have a previous underlying lung disease like asthma or COPD or bronchiectasis, as an individual who is super infected or super affected by the COVID experience. And my modalities of treatment start with inhaled therapy for the bronchial hyperreactivity, because many of the symptoms of cough and shortness of breath and wheezing and chest pain, I think, are related to the impact of bronchial inflammatory changes that cause either muscle spasm, they cause secretions, they may cause hyperreactivity, perhaps sensitivity to different inhalational exposures that in our everyday lives are not really too bothersome. But now that we've had this insult, perhaps our airways are a little bit more reactive, a little more sensitive. So you really have all of the same choices as you would otherwise have, from your inhaled steroids, long-acting bronchodilator combinations, long-acting bronchodilators by themselves, anticholinergic agents, and then of course there's the long-acting bronchodilators and the combination with anticholinergics if there was some concern about the exposure to inhaled steroids. Some people do better with that. Some people don't like the idea of steroids, which is fine. I happen to think that in this particular situation that the steroids work as an anti-inflammatory agent, a topical agent, that there's little systemic risk. And it would seem to me, from what I understand, that it is a direct therapy for the inflammatory bronchial mucosal changes that are caused by the COVID, as you might see in someone who's had another inhalational exposure and developed bronchospasm. Most of the time, in my experience, excuse me, the inhaled therapy is appropriate and it works well. You can climb the ladder to systemic steroids. Sometimes prednisone is necessary for people that, for example, I usually think of prednisone as having to put the fire out. And whether that's a COVID situation, an asthma exacerbation, a COPD exacerbation, a sarcoid exacerbation, prednisone generally puts the fire out, to be followed by a lower exposure inhaled steroid or a combination thereof. And we try to use less steroid than perhaps historically we have. The usual course for someone with a COPD exacerbation would be about 40 milligrams a day, one time a day for 5 days. That's a good starting point. It's a good model for how to use prednisone in this circumstance. Sometimes there's a gradual taper. And the way I determine whether or not I'm stopping cold after 5 days or whether I have a gradual taper is really the symptoms. It's symptom driven. So for example, if I'm not feeling in my gut that they're ready to transition to an inhaled steroid, that I think sometimes or they fail to transition to an inhaled steroid, I might taper gradually until I feel that the situation has calmed down enough to then be able to be controlled on an inhaled steroid. So be careful for steroid-related adverse effects. They can be variable. Usually we think of them with higher dose for longer periods of time, but some people, won't tolerate prednisone because they're perhaps, phenotype is that they will become more affected by the steroids. Some people with underlying psychiatric disease don't do well with the steroids. It tends to exacerbate that at times. Other things like fluid retention, weight gain, etc., lipomatosis, those sorts of things, they take a lot more time. But some people just don't like the steroids and they want to get them off more quickly. And as I said, you can augment and transition to inhaled steroids or the combination agents. And sometimes in that transition, what you want to do is start both at once, or at least provide an overlap period of time so that the inhaled steroid has some surface activity that's developed while the systemic steroid is tapering down or finishing its course. And in that kind of situation, you can be a little more successful in that there's not as an abrupt transition off the prednisone. I've seen this to be particularly good for bronchospasm type of situations. Certainly anti-tussives like just symptomatic treatment, Tessalon, opiate-based cough suppressants are fine. Beware, of course, of the opiates. I try not to use them as much as I can, but there are some people who are just debilitated by a cough. And in those kind of situations, they may be necessary at least as a starter with transition to something that's non-opiate. Obviously, there are, those people that, it's hard to determine the severity and impact of their cough, and you trust that, when they ask for opiates, that's something you have to know your patient. But symptomatic treatment helps. The duration of therapy is unknown. As I said, these folks just moved in down the block. Don't really know exactly how all things should go. And what I've found is useful is a longitudinal dialogue about symptoms that assures me that I know someone is heading in the right direction. I don't have an idea that this is going to stop on a particular day or there's a certain course of therapy, and that communication and dialogue will help you to understand, what course of care they need as their symptoms resolve and what kind of duration it is. And I can say from my experience, it's different for different people. Some people fly right through it. Some people have recurring symptoms that go on for some period of time. There isn't any time limit that says if it persists more than 7 days, 10 days, 14 days, or whatever, that this is something else. Certainly, there are individuals that have different daily exposures, different, so some may have smoked, some have occupational exposures, etc. And so therefore they may be more susceptible and the duration of their recovery may be longer. The truth is, again, as I said a couple times, no one really knows what to expect because we don't really know this disease yet. Perhaps in a year or 18 months or 24 months, we'll know more. I'm sure we will, of what to expect. But the model of an asthma exacerbation, a COPD exacerbation, or even an occupational or environmental exposure to mold, to something in the environment, something at work, etc., those are relatively good models to use on how to approach this. Common sense plays a huge role in all of this. Certainly the idea of, as we treat people, let's make sure we try to avoid as much as we possibly can making anything worse. So medications with side effects, know your patients. They may have unique features that require different choices. Certainly different approaches of therapy can be appropriate for different patients. The transition from systemic to inhaled steroids is something that needs to happen at some point. Where that point is, sometimes hard to know. In general, I think avoiding the opiates is a good idea, but there are just some people that are going to need them. And patients need to be counseled. So adjust their expectations that the time frame for the recovery is unknown. And sometimes even I've had patients call, say that they wax and they wane, that they seem to be getting better, they have a good few days, then they have a bad day. A good few days and a bad day. Don't let that necessarily derail the direction you're heading. This seems to be, at least from my experience, something that you can expect. They may come and their symptoms may go, but generally think about the general trajectory of their course. I haven't seen anyone not recover, so it's early though. Long-term effects may be unusual, we just don't know what they are yet, and they may occur eventually. If something seems out of the ordinary, refer to pulmonary. That's totally fine. Certainly, I've seen them in the hospital. I'm starting to see them come through in the office. I've treated some people, co-workers, etc., as patients that I'm in contact with quite often. And, if you feel that something's not right, even if you just need a hand to hold or something like that, pulmonary services at any of the Emory hospitals, happy to see these patients and help with them. Patients that sort of cross that line and you say something's not right, I'm not sure what it is. Perhaps they do need a pulmonary function test, but this is down the road, or even a methacholine challenge to see if they have or are developing hyperreactive airway disease. These things may be abnormal, or maybe they have hyperreactive airways, but in the long term, I don't know if it'll stick. They may need to have these tests to determine at the present now. Are they going to be positive still in a year? Don't know. Hard to say. CT chest and chest X-ray offer some, but remember, infiltrates from someone who has had COVID pneumonia may persist for some time. And so just the fact that a chest X-ray remains abnormal for a number of weeks doesn't necessarily mean anything different is happening. Could it be? Yes. If there's a change, for example, in a bad way, perhaps. CT chest can identify other more subtle changes like bronchial thickening, bronchiectasis, for example, other changes that may suggest that a cavity that was not present may now be present. Something different, a pleural effusion, for example, lymphadenopathy. If you come up with those sorts of things in a patient who seems refractory, perhaps it's pointing in a different diagnosis. There were a bunch of questions that were forwarded. I think I've tried to cover some of them. We talked a little bit about imaging, pulmonary function testing, referrals, etc. We talked about the model of asthma, COPD, and bronchiectasis. Early on, I think these are good models to use. Whether symptoms persist, hard to know at this point. Bronchiectasis is something that really probably takes more time and more insult, where the pitting of the bronchial mucosa just doesn't go away, and you're stuck with chronic cough and infection. That seems to be something that would follow much later. Choices of therapy, either in patients with known or without known reactive airway disease. We talked about systemic steroids, and some Pearl ideas are, I like to use peak flow meters. This is a good way for patients to get feedback on their own status at home. And report to you, a trend, for example, or share that trend if they see you or show you, or send via the portal, or however they share the information. Aero chambers for me, for meter dose inhalers, are a must. If you're using a discus or you're using a Respimat type of inhaler, that's different, but for all the meter dose inhalers, aero chambers for me are a must, largely because I like to know that if someone tells me that they're not doing well, that they are getting a full complement of medication inhaled, and aero chambers are the easiest way to get this done. We give them out to everybody. I give them out. I'm not sure what my other people do, but I make sure everybody on a meter dose inhaler has one, and I always ask them when they come back in, are you using it? Because if they're not, they're really not getting all of the medication that they could be. The medication should be scheduled. I would not use them PRN. I always tell people, definition PRN means that we're behind. So don't let the symptoms come on. Short-term follow-up is good to make sure they're heading in the right direction. Obviously, no smoking. And despite the fact that they're recovering, COVID smart behavior is necessary to continue, both for them and the rest of us, as far as the pandemic is concerned. I think that's my last slide. I'm happy to take any questions. Please feel free.
This is Jim O'Keefe. Thank you. That was perfect for the kinds of questions that at least are coming to my attention. So thank you very much for putting that together. Ted, we'll turn it to you to moderate depending on time for questions, or if you want to move to the wrap up.